Hello from Luke's Endodontics. Do any of your patients suffer from sinus infections? I'm sure they do. Today, I want to briefly talk about maxillary sinusitis of endodontic origin. The information I'm providing was obtained directly from a position statement taken by the American Association of Endodontics. First, I want to give some insight on some research that's been done on this topic. It's been reported that infections of maxillary posterior teeth show maxillary sinusitis or maxillary sinus pathology in 60% of the cases, according to Abrahams. Matilla found mucosal hyperplasia present in approximately 80% of teeth with periapical osteitis. Another study by Malin of 198 patients shows 244 cases of chronic bacterial maxillary sinusitis, and an etiology of dental pathology was found in 40.6% of those cases. Maliette reviewed CBCT scans that were consistent with maxillary sinusitis and found evidence of dental pathology in over 50% of those cases. Okay, so this is something that really should be explored. Bomelli found that the more severe the sinus infection, the more likely it was associated with dental pathology. So what are some things that you're looking for? All right, well, things that should raise suspicion are repeated episodes of your sinus infection, unilateral maxillary sinus infections, and particularly you need to raise suspicion if you had a previous unsuccessful sinus surgery. Okay. Now, I also want to dive into two unique radiographic findings associated with periradicular inflammation, okay, the inflammation around the end of the root of the sinus mucoperiosteum, and those are periapical osteoperiostitis and periapical mucositis. Okay, we're going to kind of dive into each one of those and what they look like. All right. So as a dentist, you're probably going to get this periapical osteoperiostitis. You're going to see it. It's going to have that classic halo lesion, well-defined borders. Basically, what's going on here is the cortical floor is expanding into that sinus, displacing the cortical plate upwards and inducing a periosteal reaction. Okay. As that periosteum expands, okay, so you have this thin layer of bone, and so you're just seeing that radiolucency. The way you look for it is say, oh, there's a tooth that needs a root canal. Okay, now periapical mucositis is something that might be missed. Okay, and this is one of the reasons why a CBCT scan is so important and it's so just wonderful for the field of endodontics. This is more of a tissue edema. Okay. This is where you're having a mucosal thickening, okay, and soft tissue expansion on the floor of that sinus adjacent to the end of that apex or the infected root, okay. So it's not uncommon for a maxillary palatal root with a first molar or many of the other teeth to perforate the cortical plate and to either by the infection itself, okay, forming a fistula that goes into that space, or it just didn't have cortical bone covering the end of the roots. And so when an infection, the source of the infection is within the tooth and it's going to release those toxins out in to that space, you're going to have that mucosal thickening. And that's what your periapical mucositis is. Now, we all know, as with any diagnosis, you don't want to go just off of your X-rays or your CBCT scans. Okay, so this is why it's really important to kind of check that quadrant. We're going to do some tests, observing the pulpal status if it hasn't had previous root canal treatment, to determine if this is another mucosal abnormality or if this is due to the tooth. Okay. During our examination, we're going to also look for, a failed root canal. We're going to be doing pulp vitality testing, percussion testing, palpation testing, just kind of pushing on the area, periodontal probing, mobility test. one interesting thing that patients feel when there's a tooth problem, they're going to say, well, it should hurt. I should have thermal pain, pain to hot, pain to cold. And this isn't generally present because the source teeth for maxillary sinusitis of endodontic origin or tooth origin, it's either necrotic or it's failed root canal treatment. Okay, periapical tenderness, that tenderness to the touch, also is generally absent because periapical infection is essentially draining into the sinus through a fistula and eliminating that pressure buildup. For the same reason, swelling or intraoral sinus tracts rarely form. So you're not going to have that obvious, case where you're going to see the sinus tract. So successful management of maxillary sinusitis of endodontic origin, as with any infection of endodontic origin, is removing that nidus of infection, that source of the infection, and it's within the tooth. Okay, so what are your appropriate treatment options? Okay, you can have non-surgical root canal treatment if you've never had root canal, periradicular surgery when indicated. You can also have intentional replantation. It's an option that isn't utilized as often because of the success rate. The other success rates of retreatment when optional or apicoectomy, which is your surgical option, are a bit higher. And then finally, you can have extraction of the tooth. When the source of the infection is within the tooth, removal of the tooth will resolve that infection. So if you have a patient who has an underlying persistent sinus infection, okay, especially if it's unilateral, please send it over to Luke's Endodontics. Help us evaluate for dental pathology to see if it's the root cause. Have a great day and a happy Friday. Thank you.